Good day. I'll be discussing the topic of disaster risk reduction and management in health, or DRRM-H institutionalization at a province-wide and city-wide health system in support to universal health care. The Philippines is always in the global disaster picture. The Philippines is one of the most at-risk countries when it comes to disasters. The Philippines is top 9 in the World Risk Index in 2020. This is a list of the most disaster-affected countries globally. In 2019, in the Climate Risk Index, Philippines is top 4 in countries affected by extreme weather events. This is true because of the following factors. There's increasing frequency and intensity of weather-related hazards that affect our country. We have high exposure because of our location in the Western Pacific region in the typhoon belt. Filipinos are also continually exposed to disasters because of socioeconomic vulnerabilities. Also, our adaptive capacities for managing the impacts of disasters and climate change is an area that should be improved significantly. Among the different hazards, typhoons produce the most devastating disaster impact to the country. We studied destructive cyclones that have hit the Philippines from 2011 to 2020. In this 9-year period, we had 84 cyclones that were categorized as destructive. This led to more than 18 million families affected, 69 million individuals affected, 35,000 injuries, 10,000 deaths, 1,642 damaged health facilities, and 192 health emergency response teams deployed. This also shows that most regions of the country are at risk of the destructive impacts of typhoons, having been visited by typhoons very frequently. And also, no region is spared from the impacts of typhoons. The Philippines has a long and diverse list of hazards, from natural hazards, typhoons, earthquakes, floods, landslides, volcanic activity, tornado, tsunami to El Nino, to societal, armed conflicts, explosion, mass gatherings, down the line, to technological, fire, transportation accidents, etc., to biological, represented by pandemics, disease outbreaks, food poisoning, etc. All of this pose health threats, endangering Filipinos' health and safety. Disasters have a negative impact on our health and health systems. On health, disasters can cause deaths and injuries, disease and disability, environmental health issues, psychological and mental health problems, displacement of population that can give rise to a lot of health concerns. Also, disasters can cause nutritional deficiencies. On disaster impacts to our health system, disasters can damage health facilities and other critical health infrastructure. It can disrupt our health service delivery, especially when health workers are also affected. Surveillance systems, disease prevention and control programs can be compromised as well. These system issues can exacerbate health concerns. Also, health resources and finance are diverted to response and recovery when it could be invested in preparedness and strengthening health systems. Disasters are really big health issues, the impacts of which need to be addressed. The public health sector has to respond strategically, guided by UN frameworks, especially the Sendai framework for disaster risk reduction and the WHO framework on health emergency and disaster risk management. Our health sector needs to do the following: strengthen public health systems by looking at the building blocks: finance, information management, governance, health human resources, logistics, etc. Enhance capacity of health sector to reduce risks and respond to emergencies. This is fundamental. Protect hospitals and other health facilities so they remain safe and operational during emergencies. Improving response to public health emergencies to save lives and decrease morbidity and mortality. Improve use of early warning systems to protect people from hazards. Most importantly, build the capacity of local governments and communities to make them resilient. The health sector must have this as priorities. There's a need to have a holistic approach. This is where DREAM-H comes in. DREAM-H is disaster risk reduction and management in health. This is an integrated, systems-based, multi-sectoral process that utilizes policies, plans, programs, and strategies to reduce health risks of emergencies and disasters. Through four areas, from prevention to preparedness to response and recovery or rehabilitation, DREAM-H can be realized. When this is institutionalized, these final outcomes can be achieved. Uninterrupted health service delivery, prevention of morbidity and mortality and other health effects because of disasters, and zero outbreaks. This can contribute to the societal goal of a safer, adaptive, and disaster-resilient Philippines. DREAM-H happens when there is a DREAM-H plan, health emergency response teams, health emergency commodities, and emergency operations center. Through the process of governance, health service delivery, health resource mobilization and management, and information and knowledge management, these outputs can be delivered. All in all, this will require increased investments in DREAM-H to initiate and sustain it. DREAM-H can also be seen as a comprehensive strategy for reducing health risks. DREAM-H can prevent exposure to hazards, reduce vulnerabilities of communities, and develop the response and recovery capacities of the community and response agencies. This conceptual framework for risk reduction entails decreasing hazards and vulnerabilities and increasing capacities. These are considered in DREAM-H planning. DREAM-H and health resilience are implied, if not mentioned, in these frameworks. From the Sustainable Development Goals to our Philippine Development Plan to the Republic Act on Disaster Management, Universal Healthcare Law, to the National Objectives for Health and the Formula 1 Plus for Health Strategy, to our administrative issuances on DREAM-H. We have integrated the concept of resilience and DREAM-H to move it forward. It's worth sharing that DREAM-H is mainstreamed in the updated National DREAM-H Plan, looking at safer, adaptive, and disaster-resilient Filipino communities towards sustainable development. The plan has 23 different outcomes that cut across four thematic areas. Out of this, 19 out of 23 are health-related. There is an indicator here that measures the percent of LGUs with DREAM-H plan and budget. DREAM-H is well captured and integrated in this national DREAM-H plan. The health sector should take this opportunity to work with other sectors, from the government, private sector, and civil society when it comes to DREAM-H. Furthermore, DREAM-H contributes to the National Climate Change Action Plan. As human impact of climate change is a health issue, adaptation to climate risks should include disaster risk reduction and management. For this, cross-cutting strategies such as capacity development, knowledge management, communication, etc., should be implemented, and partnerships, financing, policy, and plans should help. Health delivery systems should be responsive to climate change risks. DREAM-H can significantly help in this regard. Despite the presence of legal and policy frameworks, investments in health and DREAM, actual disaster experiences, and interrelationships among different stakeholders, the following issues still exist. We have a weak and vulnerable health system that is prone to shocks. DREAM-H is not a top priority among stakeholders, especially local chief executives. Health service delivery, although systems are in place, remains to be fragmented. Coordination is the main challenge. In addition, there's not enough human resources, logistics, and money to finance DREAM-H. Evidence-based decision-making, utilizing data, has to be improved badly. RA 11223, the UHC Act of 2019, specifically its IRR, recognizes public health preparedness and response to be critical in service delivery. Under population-based health services, province-wide and city-wide health systems shall have timely, effective, and efficient preparedness and response to public health emergencies and such other means to ensure delivery of population-based health services. What has a Dream Age system got to do with public health preparedness and response? Having a functional Dream Age system can help improve our preparedness and response to public health emergencies. One big component of the province and citywide health systems. A functional Dream Age system made up of four elements can, among others, improve public health preparedness and response. A functional Dream Age system has four elements as shown here. In the LGU scorecard, we will look for four components. First, the Dream Age plan, which must be approved, updated, disseminated, and tested. Second, the health emergency response teams, who must be trained and organized. Third, health emergency commodities need to be available and accessible. Lastly, having a functional emergency operations center that has command, control, coordination, and communication features. DRRM-H institutionalization will help guarantee uninterrupted delivery of health services in emergencies and disasters. Through DRRM-H activities in the four thematic areas of prevention and mitigation, preparedness, response and recovery, and rehabilitation, guided by the core processes of governance, service delivery, resource management, and mobilization, and information and knowledge management, we can build a functional DRRM-H system with the four components: the plan, teams, commodities, and functional operation center. This will help us deliver our service package in emergencies and disasters, namely medical and public health, nutrition, water sanitation and hygiene, and mental health and psychosocial support. To decrease preventable morbidity and mortality in emergencies and disasters, the essential health service packages, the four clusters of services, need to be delivered. They are medical and public health, which includes life-saving measures, prevention and control of communicable diseases, prevention and control of non-communicable diseases, maternal, newborn, and child health, sexual and reproductive health, early treatment and continuation of treatment for acute and chronic conditions, and health support services for vulnerable population. Nutrition, which includes community health and nutrition interventions, infant and young child feeding, rapid nutritional assessment, micronutrient supplementation, management and referral of malnutrition cases, targeted supplementary feeding, counseling and supportive nutrition care, and even Milk Code Act monitoring. For water sanitation and hygiene, WASH assessment and evaluation, provision for safe water and storage and protection of sources, hygiene promotion, vector control, provision for solid waste management, provision of sanitation facilities, excreta disposal facilities, water quality surveillance, disinfection and treatment, and drainage of wash facilities. Finally, mental health and psychosocial support, provision of psychological first aid and other interventions, utilization of various approaches in healing, referral of cases to specialists and higher facilities, community mental health interventions, education, assessment using existing guidelines, protection and promotion of responders' well-being, and provisions for psychotropic medications. Effective health response to a disaster relies on the functional DRRM-H system. In this response management framework, it is imperative to manage the event or incident by way of activation of an incident command system, activation of the operations center, initiating coordination and triggering the early warning and alert response system. In managing victims, we need to implement mass casualty management systems, prepare the evacuation centers, address surge capacity in hospitals, even manage the dead. In managing the response, we can deploy different health emergency response teams to provide the needed health services. Logistics, finance, and lifelines need to be managed as well. Data and information management, knowledge management, and documentation should also be done considering information is critical for decision making. All of this should be clearly spelled out in the DREAM-H plan, and preparation should be done to make these components of the different systems available during response. For DREAM-H to be institutionalized as part of UHC, DREAM-H integration in the managerial, technical, and financial aspects needs to be realized. For managerial integration to be realized, the following should be done. Institutionalization of DREAM-H system and integration to the local health system of the province and citywide health system by forging commitments, building mechanisms of cooperative undertakings with stakeholders, sharing resources within the network, identifying the role of provincial and city health officers and the province and city health board, appointing a DREAM-H manager, and conduct of performance monitoring. For technical integration for DREAM-H to happen, the aspects of governance, service delivery, resource management and mobilization, and information and knowledge management should be observed. For governance, policy, planning, program, standard system development, command and control, coordination and communication, partnership, monitoring and evaluation, promotion and advocacy. For service delivery, engagement and resource sharing, provision of essential health service in coordination with partners, mass casualty incident management, safety of health facilities through hospitals safe from disasters, under resource management and mobilization, development of manual of operations or process algorithms, strengthening logistics management, continuity of health services. Finally, for information and knowledge management, establishment of public health operations center, utilizing and upgrading an information or knowledge management info system for evidence-based decision making and actions. For financial integration for DREAM-H, the following should be done. Delivery of population-based health services financed by the government at the point of service. Use of special health fund, investments on DREAM-H through local investment plans for health, other financing and other sources, such as but not limited to donations, grants, and other forms of technical assistance. Indicators at different levels of DREAM-H institutionalization will be used to measure progress and success. For preparatory, preliminary survey of DREAM-H status, documents adopting DREAM-H, focal DREAM-H representative. For organized, policy and organization of DREAM-H system, appointed or designated DREAM-H manager, a DREAM-H plan, health emergency response team, essential health emergency commodities, emergency operations center, special health fund, and other fund sources for DREAM-H performance monitoring. For functional, DREAM-H updated and tested, health emergency response team sustained, cluster membership, resource sharing, functional operations center, program management, sustainability of DREAM-H program and operations, performance monitoring sustained, lessons learned, and good practices documented. Local government units, especially the province and citywide health systems, should perform their roles and responsibilities in DREAM-H institutionalization through compliance to latest standards, delivery of expected DREAM-H functions and essential services and products, participation in capacity building, promotion and advocacy, monitoring and evaluation, building partnerships, using funding for DREAM-H, investment and upgrade of health system. On the part of the Department of Health, we will provide technical assistance on DREAM-H through the following DREAM-H menu of activities. These are things that are essential to be done at the regional and local levels to institutionalize DREAM-H. Against this, we also show here our DRH support to leverage our expertise and resources. This is based on our performance monitoring assessments, program reviews, and validation of CHD and LGU needs over the years. First, it is essential to develop and update the different disaster plans. On this, we provide technical assistance through guides, templates, orientation, mentoring, and coaching. Second, trainings have to continue to capacitate our important human resources. Our role is developing the modules, converting to e-learning, and support the training systems in terms of trainers, networks, even equipment. Third, conduct of promotion and advocacy activities. For this, we have the plan and IEC materials for dissemination and adaptation. Fourth, organization and mobilization of health emergency response teams. We are currently doing guidelines on this, operationalizing existing policies, and our major commitment here is on the training. Fifth, support to resource mobilization and ensuring functionality of the operation center. For this, we do the guidelines, provide trainings, augment logistics, and provide financial support, especially during disasters. Lastly, conduct of monitoring and evaluation. We are working on our M&E toolkit and will do orientation, mentoring, and coaching. Health resilience should be part of UHC. When we say health resilience, we mean our capacity to absorb, adapt, and transform when exposed to a shock. In our case, all kinds of hazards, and still retain our control over our structure and functions. This is our aspiration. When we look at the resilience of our health system, let's go back to the building blocks of our health system. Let's do GMH by doing prevention or DRR, preparedness, response, and recovery. Let's also remember the social determinants of health in our approach. Do health emergency programs, enhance our coordination, and do our best to build community resilience. This holistic view of health resilience is important in thinking about how DREAM-H can be realized as part of UHC. The ultimate goal of all disaster and climate management strategies is improving human health. Health is central to building resilience. We need to build resilience one LGU at a time. Let's do GMH together so we can make health resilience happen. Let's work on 5K. Kaligtasang pangkalusugan sa kalamidad sa kamay ng komunidad. Mabuhay po tayong lahat. Thank you.